Hello, this is Mrs. Condry. This is Intraoperative Care NUR 1213. Our objectives is that you will identify key assessments and interventions for this intraoperative period and explain the rationale for those interventions. We just did the third objective in the previous PowerPoint, and the fourth objective will really be done in the next PowerPoint. The physical environment consists of a holding area where the patient comes in, gets into the gown, is assessed, goes over the paperwork, and they're waiting to go to the OR. The OR is a controlled setting where there are filters and it controls the dust. There's positive air pressure to prevent air that coming in from the hallway, and there may be UV lighting to decrease microorganisms. And the OR staff wears the caps to prevent hair going into the environment, and booties to prevent us dragging nasty organisms into the OR. Some institutions allow parents to be present during the induction of anesthesia, although personally I've never seen that. Others may give small amounts of IV sedation in the pre-op area so that the child will be asleep. And I personally have had several times where my child has been dragged off screaming while I'm in tears because my child is screaming, and I'm worried. So I'm hoping that things have changed since then and that they are doing the small amounts of IV sedation for children. And then the post-anesthesia care unit will be explained in the next PowerPoint. So the surgical team consists of a perioperative nurse, and that nurse can be a scrub nurse or circulating nurse. So a scrub nurse assists the physician. A circulating nurse is not sterile, is going around the OR assisting people with tying their gowns, opening gloves, the packages, getting any equipment that might be missing. Licensed vocational nurse or surgical technologist may take place of either the scrub nurse or circulating nurse, but the RN must supervise. And I personally have not seen an LVN in the OR. This county, Brevard County, is using surgical techs, and Eastern Florida has a surgical tech program that's a 2-year program that allows them to assist the physician. The surgeon does the actual procedure, but they may have an assistant, and there's may be a registered nurse first assistant who works with the surgeon. They need special training. It can be a nurse practitioner who has gotten special training to do that, and then there's always an anesthesia care provider. That may be an anesthesiologist, the actual physician, or it could be a nurse anesthetist, CRNA. That nurse goes to school for another 2 years after their bachelor's, and it's usually a full-time school. It's very rigorous to become a nurse anesthetist. The physician or the actual anesthesiologist is responsible, so that doctor comes into the pre-op area to interview, as well as the CRNA comes into the pre-op area to interview that patient. I haven't seen an anesthesiologist assistant, which is a PA who has specialized in this, but I'm sure that there are many around in the United States. So as a nurse, our responsibility is to review the chart in the pre-op area. We review it with the pre-op nurse. We're going to make sure that the room is prepared. Even though you personally may not have to prepare it, we have to make sure that all the equipment and attire is in place. We're going to transfer the patient safely, apply all the monitoring equipment, cardiac monitor, O2 sat, capnography, oxygen, make sure that sterile technique is performed, that all the gowns and gloves and everything is there, used appropriately. Then the most important thing, I think, is a timeout. And this is now required because of several wrong site, wrong surgeries. We had one here in Florida on the West Coast where the wrong limb was cut off. And so after that, to prevent that from occurring, there's now a requirement that hospitals perform timeouts, not just hospitals, but outpatient surgeries as well. So you just have all the staff stop and they say timeout, ask the patient's name, date of birth, what they're having done, who's the physician, just to assure that they're doing the correct procedure and on the correct site. And that's also why the physician marks right and wrong and yes for the correct site if it's a limb that needs to be fixed. The nurse is going to make sure that the patient is positioned properly to make sure that there's no pressure or occlusion to any nerves and vessels, because that can cause pain for years. We're going to prevent hypothermia by applying warm blankets. There's usually a blanket warmer in the OR, and it's usually the surgical tech that prepares the surgical site, but it may be the nurse scrubbing it with the disinfectant. Could be Hibiclens, could be chlorhexidine. And then after the procedure, we count all the equipment to make sure that nothing was left in the patient. And then we're going to accompany the patient to PACU to give a face-to-face report. There are several anesthesia techniques. The first is a monitored anesthesia care unit, and it may not be a unit, but just maybe diagnostic or therapeutic procedures in or outside of the OR, and there's various levels of sedation, and this could be for like a colonoscopy. There's moderate to deep sedation. Those are procedures outside of the OR, and it can be the anesthesia. It's not anesthesia. It's usually benzodiazepine and opioid that is administered under the supervision of the physician. So I work in TEE, or transesophageal echocardiogram, where we put a probe down the patient's esophagus to look at the heart. And I give moderate sedation for that, also for elective cardioversions to shock the heart. And so I need to give that under the supervision. So I ask the doctor, okay, do you want 1 of Versed, 2 of Versed? And then there's general anesthesia for longer procedures, or depending on the location of the incision site, or those whose ventilation must be controlled. So I had a patient a few weeks ago who I was giving moderate sedation, 1 milligram of Versed, and the patient was pulling on the doctor's hand and wouldn't let him place the probe. So I gave another 1 milligram of Versed. She's out cold. Her O2 sat drops down to the 50s. I had to reverse it. We had to bag her. So she couldn't safely be given moderate sedation. So she had to go to the OR the next day to get this procedure that normally is done with moderate sedation. General anesthesia is loss of sensation, loss of consciousness, and it requires advanced airway management. So these are pictures of an ET tube, endotracheal tube. This is the endotracheal tube. And then there's an LMA, which doesn't go down as far. It might be for a patient like me who is not, doesn't have a big neck. It might be for a shorter surgery, not as difficult to manage. So they're given intravenous induction agents, and they need to have the LMA or ET tube placed quickly because the patient won't be breathing. There's an inhalation agents that is a gas mixture of the drug with oxygen, and it's administered through the alveoli, through the LMA or ET tube. There are adjuncts often given, like opioids, like fentanyl is a very quick-acting opioid that assists with the anesthesia. There's benzodiazepines, and those are usually, it's Versed, which is midazolam, is the generic name, and it is an amnesia drug as well. So that makes it nice as an adjunct and as moderate sedation. And there's muscle relaxants and there's antiemetics. Antiemetics are used quite often because, of course, anesthesia can make people. And then there is dissociative anesthesia. And this interrupts our associative brain pathways, and it blocks the sensory pathways. So the patient might be appear catatonic. They don't remember it, but they have profound analgesia. They can't feel anything. And this was the drug that Michael Jackson used, and then he died from it because nobody was there controlling his airway. There's local and regional anesthesia as well. There's the local anesthesia interrupts the nerve impulses by altering the flow of sodium into our nerve cells. It can be injected, can be nebulized, and it can be applied topically into a specific area of the body. Then there's regional anesthesia, which is injected into a central nerve or group of nerves to an area remote, such as a nerve block for shoulder surgery. This works really well that the patient can't feel it, but they might be awake. And then they could have moderate sedation or monitored anesthesia care used in conjunction. There's spinal anesthesia, which is injected locally into the cerebral spinal fluid. It may cause vasodilation, or it does cause vasodilation, and the blood pressure might drop. So we do have to monitor, of course, vital signs very frequently during the OR. The client doesn't feel any pain, and they can't move. An epidural, which is many women who've gone through childbirth have had, that injects anesthesia into the epidural space, but not the actual cerebral spinal fluid. In low doses, they won't have any pain, but the patient may still be able to move. In higher doses, there's no pain and the patient can't move. And the epidural can be continued via a patient-controlled analgesia, so a button. It can be continued post-surgery. An autonomic nervous system blockade may occur with either spinal or epidural. And the patient may all of a sudden feel that they can't breathe. And the other symptoms that you may see is hypotension, bradycardia, nausea and vomiting, and apnea. So I actually had a student last semester that she had an epidural and she ended up having this and she coded. So it does happen. Apparently that it was a little bit too much anesthesia and she couldn't breathe. And she told the staff, I can't breathe, and they didn't believe her. So please believe your patient when they say, I can't breathe. Other complications might be a spinal headache, and they usually lie flat for a while. They might have back pain, nerve injury, and they actually may get an infection, which is meningitis. Pediatric and older patients may react differently to medications, differently to anesthesia, and they may have more blood and fluid loss. They can get hypothermia more easily. They may tolerate pain differently, and they might have difficulty with positioning, especially the elderly. Communication can be difficult with both older and younger clients, and it might be because the patient can't hear. They had to remove their hearing aids. They can't hear a thing, or they can't see because they had to take the glasses off, or a child may not even be able to speak yet. Catastrophic events in the OR can occur, as I was just telling you. There may be anaphylactic reactions to any of the drugs. Usually it's antibiotics, and it could also be an allergy to latex. But anesthesia might mask those symptoms, and the symptoms might be hypotension, tachycardia, and a bronchospasm, and pulmonary edema. There's also something called malignant hyperthermia. And that's a rare disorder, and it causes a high temperature and it causes skeletal muscle rigidity. And the patient may have cardiac arrest and they can die. It occurs in susceptible people with some anesthetics. It can also occur from stress, from trauma, from heat. MH is an autosomal dominant trait, so that's another reason why we are doing the history prior to the procedure. So it's very important to find out if the patient has a history of that in the family. So the key assessments, we are going to make sure that the timeout is done, that the proper safety techniques are done, that the correct anesthesia. So if you have a patient with a really big neck and who says he has a history of sleep apnea and they decide to do moderate sedation, you as a nurse can say, I'm not sure that's such a good idea. We're going to monitor the patient, make sure the vital signs are fine, monitor to make sure the positions are correct, that if the patient's blood pressure drops, we're going to do something about it, that we're going to protect the patient from getting hypothermia, make sure that the patient doesn't have pain, and monitor for these catastrophic events. Hopefully they won't occur. And that's it for this. Thank you very much. Alt.